And then Kimberly, thank you very much for accepting this invitation. The floor is yours.
Great, thank you for the introduction, Dr. Lakatos. So as Dr. Lakatos said, my name is Dr. Carriere, and I'm a clinical psychologist, and I've been working at the IBD clinic for about a year now. And again, it's a super amazing team, and similar to what Dr. Lakatos was saying, I did research in the area before, and I always kind of wanted to have a niche as a gastropsychologist. So I ended up kind of finding a right home. So it's very special to be a part of this clinic and kind of a part of this community. So today I'm going to be talking about, as Dr. Lakatos was saying, the gut-brain connection and its role in IBD management. And before I start, I just want to say thanks to all of you who are here. As he was saying, it's very special. I can see now we're at 83 people, so very cool. So we'll jump into it. I'm going to give you a little bit of a roadmap as to what this talk is going to be about. But before I kind of get into this roadmap, I'm going to kind of preface what this talk is going to be about. So in terms of making this talk and kind of picking subjects in terms of what I can discuss, I really wanted to give it more of like a roadmap in terms of kind of showing you really what is out there right now. I wasn't going to spend a lot of time, and I didn't really want to spend a lot of time looking at very specific things. It was more kind of just giving you a kind of an entire picture, not even an entire picture, but a certain complex picture in terms of like what is the gut-brain connection and what is it implications for GI disorders, but what is the implications also for our mental health, and how are those two things related? So you'll see the stuff that I'm touching on is very hopefully is going to be appropriate for everyone kind of in this obvious in terms of like complexities. But again, if there are certain topics that I'm bringing up that are of interest to you and you want to kind of explore more about this certain topic, at the end of the talk, there's going to be, as Dr. Lakatos was saying, an opportunity where you can ask questions, but I'm also going to be providing my coordinates where you can just reach out and I can kind of point you to certain directions where you can go to do kind of more of your own explorations if you want. So today we're going to be talking about many different things, primarily the gut brain, and I'm going to start by kind of preferencing this talk in terms of talking about the modality at which I work through as a psychologist, which is really the biopsychosocial model of care. And by that, I'm going to be talking about, its implications in this gut-brain connection in individuals who live with IBD. And then talking about the implications of this gut-brain connection for our health, not just our physical health, but also our mental health, because you're going to see that they're very intimately connected. And after we talk about those things, I'm going to jump to an opportunity where I think is like really one of the most important parts. It's like, well, we're starting to point to all of these problems or these potential issues, and it's like, well, what can I do about it? And I'll give you a little bit of my 2 cents as a psychologist working in this population as to what I think we can do in terms of helping ourselves. And then I'll leave some questions, some time at the end, hopefully, where you guys can ask some questions or we can have some feedback and a little bit of back and forth. But similar to what Dr. Lakatos was saying, please feel free to write your questions in the chat because he's going to be going through these questions as we move forward. So before we get started to talk about the gut-brain connection, as I said, I wanted to talk a little bit in terms of like where I come from. So as a psychologist, you can get trained in many different modalities. And one of the things that I was interested in, even at the beginning of my training, was this connection between our mind and our body. And what does that actually mean? Well, it's really an interest in terms of looking at how our psyche or our mind can actually affect our physical health, but also how our physical health can actually affect our mind as well. And the model at which I kind of navigate this world, I guess you could say, is through the lens of what we call the biopsychosocial model of care. And this was created by a guy that was called George Engel in the 1970s. And really the main premise of this modality of care is this idea that if we want to understand an individual's physical wellness, where it's their psychological wellness, but also their physical health as well, we need to understand it as a complex interaction between their biology, their psychology, and their social elements. So I think one of the best ways of illustrating this is when we talk about chronic pain. So when we talk about an individual's pain perception, pain is not a perfect ratio, like a one-to-one ratio between pain perception and tissue damage. So for example, my pain perception or the intensity at which I feel pain might not be the same of the intensity at which Dr. Lakatos feels pain or anyone in this audience. And the determinants of this pain perception, again, is not just based in biology. It has nothing to do with just the tissue damage, but it's based in psychology, kind of like who I am, my personality traits, my sensitivities, but also where I come from, my family history, my socioeconomic status. All of these play a huge role in terms of how I kind of navigate my pain perception and how I relate to that pain. So what exactly are these implications when it comes to individuals who live with an irritable disease or inflammatory bowel disease? And there's many implications, and I just wanted to kind of note some of them. So this idea of like, this gut-brain connection, what are the implications when it comes to this particular population? Well, we know that there's a higher proportion of anxiety and depression in patients who live with IBD compared to healthy matched controls. So these are just some basic stats. So about 1 in 3 patients report symptoms of anxiety. About 1 in 4 patients report symptoms of depression. And that we know that patients who are in an active phase of their disease will be reporting higher prevalence rates of certain symptoms of anxiety and depression. So we know that there's some sort of a link between these two, between the gut and the brain. And the higher prevalence rates, like it depends on the studies that you're looking at, but the prevalence rates could be up to 50% to 80% of patients who are in the active phase of their disease will be experiencing these types of symptoms. What we also know too, based on the research, is that stress can also exacerbate GI symptoms in patients with IBD, and symptoms also patients who are living with IBS as well. So, today we're talking about the gut-brain connection. So like, what actually is the gut-brain connection? So the gut-brain axis is, we can think of it as this two-way communication system between our gut and our brain. And really, the whole point of this axis is really, the purpose of it is really to help maintain homeostasis. So our body always wants to stay in a certain level of balance. So this is one of the ways that it does it. It's constantly chit-chatting with itself. And there are many different elements that make up this gut-brain connection. And these are kind of the main elements of what it is when we start to say this gut-brain axis. So the first big player in this connection or in this axis is the brain. The others is the nerves that surround our GI tract. So that's going to be our enteric nervous system. I'm going to be talking about that in the next slide. Then there's going to be the vagus nerve. There's also the gut bacteria. So these are all the bacteria that lives in our intestines, as well as hormones, which kind of help to facilitate this communication process between the gut and between the brain. So all of these elements come together. So when we're talking about this gut-brain connection, this is really what we're talking about. So when we talk about the enteric nervous system, what is it? Well, we can call it our second brain. So a lot of researchers in this field who are looking at the kind of psychological effects of our intestine and its role in the brain and vice versa, they'll talk about the second brain. So this is really what they're talking about. And the ENS is made up of two thin layers of over 100 million nerve cells that line our entire GI tract from our esophagus all the way to our rectum. And the whole purpose of the enteric nervous system is really to facilitate or to help control certain digestive processes, such as motility or the secretion of fluids. And this part of our nervous system, so the second brain, is constantly in contact with the brain in our head. And how does it stay in contact? They stay in contact through what we call the vagus nerve. So then this is a big bundle of nerves that connect our brain and our gut, and it's the second largest nerve center in our body. So you can think about this constant chit chat. I always think of them like friends almost, like our gut and our brains are constantly connected. It's like two old friends that are constantly chatting throughout the day, all the time. They're always talking. And, not only is the ENS, not only does it play a critical role in terms of controlling digestive processes, but we also know, because of past research, or the research that we've been doing,
distance.
So I'm just going to meet someone. There we go. We also know that it plays a critical role in terms of GI diseases, GI disorders, and as well as our mental health. Okay, so again, not just a player when it comes to controlling digestive processes, but also plays a bunch of other roles, which is what we're going to kind of get into. And what we know is that abnormal gut-brain communication, so this idea, you can think about it almost like our gut and our brain are talking, like you're saying, through the vagus nerve, and you can think about it like broken telephone, or that's what I'm thinking about when we talk about these abnormalities in this communication. There's multiple reasons why these abnormalities happen, but essentially it's like broken telephone. And when there's broken telephone, this can actually interfere with our body's ability to maintain this homeostasis. And so, for example, when there's GI disruptions, this can result in certain psychological disturbances, right? So this is going bottom up. But we also know that, certain emotions like stress can actually exaggerate gut responses as well. And we're going to talk about these as we move forward in more detail. There we go. So because of this intimate connection between our gut and our brain, it's one of the ways that kind of can help us understand why like certain stressful events can cause increases in certain GI symptoms, like increases in abdominal pain, increases in gas, bloating, nausea. Some people have urgency as well. And there's several theories that go on to explaining why, there's this relationship that exists. I'm not going to go into great detail in terms of explaining every single one of them, but this is just kind of to give you a brief understanding of that there are many theories as to why this might be happening. One is that it actually creates this heightened sensitivity to pain, which is what we call visceral sensitivity. What we know right now is that individuals who have IBD have a higher than average sensitivity to gut pain. And what we know is that hypersensitivity actually affects our pain perception, but that actually plays a role in terms GI disturbances, but also in terms of effects on our mental health. There are also theories about that anxiety or kind of stress-related disorders, or stress itself, can create an activation of the immune system, which causes inflammation, and this inflammation also causes kind of problems with this gut-brain axis. Another one is that there's changes or disruptions to our microbiota. It creates dysbiosis, and this dysbiosis leads to kind of an imbalance in this homeostasis, which causes problems both to our guts, also to our mind. And the other one is that, levels of stress or kind of emotional stress or anxiety alters motility. So it alters the way that our digestion is working, right? So our enteric nervous system is either going to slow down changing the speed at which the food is going through our intestines. It's either going to speed it up or slow it down. But all of these things kind of play a role in terms of creating these certain GI symptoms. And when we talk about this idea, this like what comes first, the chicken or the egg, right? So we're saying, well, okay, well, if their gut and the brain are connected, what's causing what? What's more important in terms of what starts what first? And for years, it's been thought that it's really our emotions, such as anxiety and depression, and that it's these emotions that cause these GI issues. But there's recent research right now that suggests that it might actually be the opposite. That means that, you know, certain irritations or disruptions in the GI system is actually the thing that's sending signals to their central nervous system, which is prompting these shifts in our mood, which is one of the things that might explain increases in anxiety and depression during flare-ups. But again, these are all theories. But regardless as to how this works, a lot of what I'm talking about today and a lot of the research at which I'm interested in is looking at our stress response and how our stress response affects our gut. And particularly for me, I'm looking at how it affects our ability to manage our symptoms with IBD, so in Crohn's and ulcerative colitis patients. So I'm going to spend some time talking about what this system is, because I'll be talking about the stress response system as we move forward, and it's important to kind of wrap our heads around what it is. So when we feel in danger, our central nervous system kind of turns on our sympathetic nervous system. And it's this sympathetic nervous system that kicks our kind of fight or flight mode into gear. So I think we've probably already heard what the fight or flight mode is. It's kind of this evolutionary system that kind of, it's really about saving ourselves. So it's either we want to run away from something, fight something, but really the whole point of it is that there's going to be a whole pile of physiological changes that prep our body to intervene with said threat. One of the things that happens and one of the changes that happen is signals are sent to our second brain, which is our ENS that we were just talking about before, to either slow down or stop digestion. Okay, and the whole point of it is really just to focus energy on the immediate threat, saying right now you don't need to be digesting your food. We either want it to stay inside of you or we're going to get rid of it, because we really want you to be focusing on said threat. And we really want to put all of the body's energy into focusing on said threat. And this fight or flight mode was designed really for acute stressors. So I was thinking about the example of, I don't know, thousands of years ago, you're in the African savannah and you're, I don't know, met with some wildebeest, and you get this there, and there's this immediate threat in front of you, and you either have to fight or you have to run away from it. Right? So we could say that that thing that's in front of us would be an acute stressor. So my body is prepared to make all these physiological changes to either help me to run away from said wildebeest or to fight said wildebeest. And after that stress is gone, my stress system is soothed and it turns off. The problem with the system is that this system was created, again, like I said, for acute stressors, that it turns on, it's supposed to do its thing, and then it turns off. But in the modern day, most of our stressors are not acute, they're actually chronic, particularly in terms of modern stressors. So we live in a modern world where we have a lot of stress, whether it comes from our work, whether it comes from our relationships, whether it comes from our family systems. And all of these stresses are something that are very like prolonged over time, which means that our stress response is turned on constantly. And this, again, as we were saying, because of this intimate connection between our mind and our guts, it actually plays a role in terms of certain gastrointestinal symptoms that we might be experiencing. So what is this implication when it comes to individuals living with IBD? So I'm sure some of you who are in this audience right now, you know, either have Crohn's or ulcerative colitis, or you know someone that has it, right? And I'm sure all of you can say that, you know, living with a chronic disease is something that is incredibly stressful. And particularly when it comes to, you know, compared to other types of diseases, Crohn's disease and ulcerative colitis, there's an unpredictability about it because of the cyclical nature of it, right? And because of it, there comes a whole bunch of other feelings, right? So feelings of uncertainty, there's feelings of fear, A lot of people experience feelings of shame, right? Because it's a very taboo topic. We don't talk about, bowel movements usually in the Western culture, right? And these are diseases that are affecting our intestines, affecting the frequency at which we're going to the bathroom, right? These are things we don't usually talk about, and there's a little shame around it. And all of these types of emotions create and really unintentionally keep our fight or flight mode on. So it keeps our stress response on because they're almost perceived as a sense of threat. And this is really important because for many patients, not all patients, I don't want to talk on everyone's behalf, but for a lot of individuals with Crohn's and ulcerative colitis, their disease has this potential of being perceived as a threat that cannot be evaded. And why am I talking about this? Well, this is something that I think is very, very important to highlight, which we don't necessarily do when it comes to IBD care. So there's a difference between a stressor that is something that's outside of us versus something that's inside of us. So there's different psychological implications in the sense that, yes, I can be surrounded by certain stressors, but if they're outside of us, there's a capacity at which I can remove myself from said stressor. Not always, but there's a potential in terms of a level of control. But when we're talking about a type of stressor that is within us and something that I cannot evade, this becomes very, very, very threatening. And it's something that is very, very hard to wrap your head around. And why am I mentioning this? Well, because it kind of goes into really what my area of expertise in is, what I'm interested in when I'm looking at this population is this, and it's something that I think that we need to talk about more, is that a lot of patients with inflammatory bowel disease meet criteria for what we would call post-traumatic stress disorder. So there's been research right now, a lot of it's preliminary, but they look at big cohorts of patients who have been either recently diagnosed or have been diagnosed for like over quite some time, and they assess their levels of post-traumatic stress symptoms. And what they found is that about 30% of patients meet criteria for PTSD. And for me as a clinical psychologist, I was like astounded by this number. And why do I say this? Because, and I'm trying to, there's some stats underneath just to give you a bit of a picture as to what are the implications of this. Well, in the US, the prevalence rates of PTSD, meaning that the amount of people who meet criteria of PTSD, is 3.5%. Across a lifetime, let's say I went outside and I collected a whole bunch of people, and I said, what is your risk of ever developing post-traumatic stress disorder that meets criteria for PTSD? It would be about a 6 to 8% chance, right? So you can see the distinction. That's a huge discrepancy. So the individuals who live with IBD are at a very, very high risk. It's a 1 in 3 chance of developing these types of symptoms. And for me, why is this so important that we start to talk about it and start to do more research on this, is because we know that individuals who are diagnosed with PTSD, they have a higher risk of complications when it comes to their IBD management. So they're going to be less likely to ever find themselves in remission. They're going to have more flare-ups. They're going to have more complications in terms of surgeries as well. And we also know that they also have a higher likelihood of having anxiety and depression, a whole other psychological comorbidities as well. So for me, it's something that I think needs to be more routinely assessed. It's something that we really, really need to address because of the implications in care. Okay, so I'm gonna go, this is a little bit, we're gonna take a little bit of a turn, and we're not sticking to PTSD, but it's all related because we're talking about the stress response. So I want to do a little bit more in terms of, okay, well, what do we know out there right now in terms of gut-brain dysfunction and its effects on our kind of GI tract? So what we know is that a common condition, and it's very clear right now, we have enough information to say this, or enough research to say this, that there's a common condition that arises from this miscommunication between the gut and the brain, and this common condition is IBS. So irritable bowel syndrome. So IBS is like a functional GI disorder. So what does that mean? It just means that if I were to look at someone who has IBS or symptoms of IBS, their intestines would look fine. So there would be no inflammations, there would be no indications that anything is really wrong. But it doesn't mean that your symptoms aren't real. So individuals with IBS still experience symptoms that are really really similar. They map on similarly to certain symptoms that individuals with IBD experience as well, such as abdominal pain, bloating, gas, diarrhea, constipation, and nausea. So IBS globally affects about 1 in 9 people. We know that people who live in a modernized world, so more of Western societies, experience rates of IBS more than non-Westernized societies. It kind of makes sense if you start to understand the effects of our stress on our gut and on our gut systems, right? Modernized societies, higher levels of chronic stress, like that I was talking about before. We know that chronic stress affects our gut, so you can kind of make the distinction. And what I think is also important to think about too is that 30 to 40% of patients with IBD report IBS type symptoms during periods of remission. So these are periods when we think that, my disease is inactive, there is no inflammation markers, everything's okay, but I'm still experiencing certain symptoms that seem related to my IBD, but I can't wrap my head around it because everything looks fine. All my bloods are coming back fine, everything's fine. So we know, again, 30 to 40% of patients will still be experiencing symptoms, and we call these IBS type symptoms. And when in remission, IBD patients are about 4 times more likely to experience IBS type symptoms compared to healthy matched controls. So the risk of experiencing these symptoms, we had people who are in remission, healthy controls, you'd say that those people in remission who have IBD are going to be at a 4 times higher risk of developing those symptoms. We know that the prevalence is slightly higher in individuals with Crohn's disease. There's some theories as to why this is. One of the reasons could be just that the severity of this Crohn's disease tends to be more severe in terms of its life course. And given the severity of it as well, there might be more inflammation, but it's also just like psychologically more to wrap our head around too. In terms of, like I was saying, living with a chronic disease is already stressful. And if we have a severe disease, it just makes it that much more stressful. We also know that IBS is more prevalent in individuals with mental health problems, as well as people who score high on ACEs. And I'm going to talk about this in the next slide. And what we also know is that symptoms worsen with stress. Okay. So to talk about ACEs, because I think it's something that's very important, and again, something that's very interesting for me, is that, so when you're a child, we have certain kind of developmental milestones. And we know that if an individual goes through certain developmental milestones and they experience certain adverse childhood events, their likelihood for developing a bunch of physical problems and mental health problems become higher. The risks kind of increase. So researchers created this questionnaire, and it's one of the main questions that's been used, where they start to actually look at, adverse childhood events that happen during these prime developmental years. And these types of events are kind of range from either abuse, whether it's physical abuse, sexual abuse, emotional neglect. And what they do is they have people answer this questionnaire and tick off the types of events that they might have experienced in their households when they were younger. And then you get an ACE score. Okay, So that's higher scores mean that you've had more adverse childhood events compared to lower scores. Okay, and what they do with these ACE scores is they start to try to understand, is there certain associations between ACEs or ACE scores and certain physical manifestations of diseases or mental health problems. So what we know in general, again, they just started to do research when it came to this and IBD. And what we know is that higher rates of ACEs, what they found is that there's higher rates of ACEs in IBD populations compared to healthy matched controls. So just from the get-go, if I took a group of individuals with IBD, if I took a group of healthy matched controls, the people in the IBD group are just going to, on average, have a higher ACE score. What they found is that there's really no differences between people with ulcerative colitis and Crohn's disease, or they haven't found differences yet. What they did find, though, is that physical abuse, so again, I'm saying ACEs run on sexual abuse, physical abuse, emotional neglect. What they found that individuals who scored ACEs in physical abuse had higher risk for developing anxiety in adulthood. But what they found in terms of IBD populations, what was more generally found was that a lot of the ACE scores that were occurring were scores that had to do with emotional neglect. And why did I put a little star here? Well, I'm going to talk about this later on when I talk about things that I've noticed as a psychologist working with this population. But to preface it, you know, sometimes we think physical abuse is worse than emotional abuse. I would almost say that they're just as bad, but for different reasons. Emotional neglect, when we're developing in our childhood, we learn about our emotions, about talking about emotions, about identifying our emotions, about holding space for our emotions in our childhood. If we were raised in an environment where we did not receive that, or we had no opportunities to really hold space for emotions, or have people to kind of map and mirror us, to tell us like, this is what you're feeling, help us kind of process these sort of things, we never learn that as a skill. Being able to identify emotions, talk about emotions is a very important skill, especially when it comes to regulating our stress. So again, going back to this kind of distinction between the gut and the brain, and how these certain stress response can affect our gut, it kind of makes sense. And it's something that's very important, and I'll talk about it later on as we move forward in terms of things that we can start to think about to kind of help ourselves. But again, this is all to preface that a lot of this research in this area was all, what it was very, we call it cross-sectional. So they give a bunch of questionnaires and they kind of make associations based on the questionnaires. It's not longitudinal. It wasn't across time, which means that we can't talk about causality. So we can't say, you know, my emotional neglect or my physical abuse is what led to me developing IBD. We just can't say that. We can say that there's an association between the two, but we can't say what caused what. So, you know, given all this that we were talking about in terms of our enteric nervous system and kind of, you know, the implications of our mind and how it may affect our gut and how our gut may affect our mind, you know, we kind of ask ourselves, well, what are the implications when it comes to therapy? And well, because of this intimate connection between our brain and our gut, it might actually help to explain why certain mind-body therapies and certain medications actually help alleviate some mental health symptoms, but also some GI problems as well. And because both of these brains are chit-chatting all the time, therapies that either target the mind or therapies that target the gut will benefit both because of their intimate connection. So there's been not a lot of research. There's always more research that needs to be done, But from what we know, there are psychological therapies and mind-body therapies that have been shown to be effective in clinical trials for reducing symptoms in patients with IBD. And one of the therapies is mindfulness-based therapies. One of the types of therapies is what we call acceptance commitment therapy. And I'll talk a little bit about it so it makes sense, so I'm not just giving jargon. But really the whole preface of these types of therapies is really like, there are some things in our life that we cannot change, right? And in those moments, what I can control though is the way I relate to said thing. So a lot of the time, that's really the basics of mindfulness-based therapies, is helping you relate to your painful experiences differently, in a way that's more open, in a way that's more kind, that's less judgmental, more accepting, to help you kind of soothe that system in terms of your stress response. And ACT does a really great acceptance commitment therapy, is one of those types of therapies that does that. There's also been quite a bit of research, more research on IBS, but there's been some research on IBD as well, with gut-directed hypnotherapy for alleviating symptoms like abdominal pain, bloating, gas, stuff like that. For patients with IBD, patients who also experience IBS. The thing about gut-directed hypnotherapy is that it's very hard to find a registered hypnotherapist who specializes in this gut-directed approach. But because of this, there's been research that researchers who created an app, which is called Nerva, if any of you are interested. And there's quite some interesting research actually on the benefits of this app for helping alleviating certain IBS type symptoms in, again, patients with IBS, but patients with IBD as well. There has also been clinical trials looking at cognitive behavioral therapy and its effectiveness in patients with IBD. And I have nothing against CBT, but I guess I put a note of caution just because of maybe my orientation, or maybe my understanding of CBT, or what I've kind of seen over the years, is that sometimes, like I said, certain things we cannot control. When it comes to CBT, and it might not happen to every single patient, but sometimes I've noticed that certain patients, CBT is really about kind of challenging certain thoughts. And some patients, depending on those types of patients or those types of clients, they kind of get in this like struggle with themselves, that they're not able to kind of challenge their thought properly, and that they still have certain thoughts. And that there's this kind of underlying message that it needs to be different. And I'm only putting this as a note of caution because mindfulness-based therapies are very different. It's more this idea of you don't really need to change the thought, right? The thought is going to be there, and like, that's okay. I'm learning to relate to that thought differently. Whereas CBT is very much trying to kind of grapple with thought and change it and convince myself that it doesn't need to be there. So it depends on the type of person you are. But in general, really the whole point of these types of therapies is to really help you learn how to soothe your stress response, right? Knowing that the more I soothe the stress response, there's going to be benefits not only for my mental health, but also for my gut health as well. So just a special note, because I've been talking about more of this kind of like top down versus bottom up when it comes to this connection between the two and how it plays a role in our health. So I wanted to spend some time kind of really prefacing, as I said, it is a bi-directional relationship between the two. So I want to make a special like call out or a note that, the gut can actually affect the brain too. And there's many ways that it can do this. And one of the ways is through a microbiota. So what they found and I'm not going to go into great detail when it comes to this, but I wanted to kind of give you like a broad frame as to what has been shown. So there has been research that has shown that these like unusual imbalances of gut bacteria have been shown to be associated with several conditions. and several conditions that seem like totally unrelated to kind of our gut health. So these are conditions such as autism disorder, Parkinson's disease, multiple sclerosis, schizophrenia. And, you know, again, this is like a note of caution. These types of studies are very, very young and very, very preliminary in terms of their understanding. But how do they kind of figure this out? Well, one of the ways is through germ-free mouse. So a lot of the time they do it with mouse models. So researchers have raised a breed of mice that they call germ-free. So that means that they literally have no bacteria in their guts. Their guts are completely sterile. What they do is they end up taking gut bacteria from certain populations, let's say individuals with autism, and they insert it in the intestines of the mice, and they kind of observe their behaviors. And what they find is when they do this, the germ-free mice before have a certain type of characteristic. After they end up doing this FMT, there's like a change in their behavior that's very similar to the types of behaviors that individuals, let's say with autism disorder, would kind of demonstrate. So for them, they're saying like, we don't quite understand what's going on here. We know that there's something that's going on here, right? So it's a lot of interesting research in that world. So, you know, okay, so what's the kind of take home when it comes to IBD? Well, so far what they know is that there is a dysbiosis when it comes to patients with IBD. So what does that mean? We know that there's different strains of bacteria, or the guts of people with UC or CD are different compared to healthy match controls. So this just means that there's imbalances, there's different strains of bacteria, more bacteria, less bacteria than people who would have, people who don't have this disease. So what does that mean? Well, then because of this dysbiosis, researchers are trying to see, well, like, can we actually start to kind of rebalance the gut and actually see if that leads to kind of benefits in the, you know, our gut health? And one ways they do it is through, you know, probiotics, prebiotics, fecal matter transplants. And one of the best I guess, like illustrations right now of fecal matter transplants is with patients who have reoccurring C. difficile infections, where there's just an overpopulation of certain types of strains of bacteria, and antibiotics are not wiping out the C. difficile. So what they end up doing is they're taking bacteria from healthy donors, and they're putting it in the guts of patients with C. difficile in an attempt to reestablish their disrupted microbes, and it works very well. So what they're trying to do is kind of similar things when it comes to taking certain bacteria from healthy donors and trying to put it into patients with UC or CD, and kind of seeing, does that actually help to improve or kind of recalibrate these guts that seem to be dysbiotic, and seeing whether it's going to have an effect on the inflammation markers, or it's going to have an effect on certain types of symptoms. And right now there is preliminary evidence that it is helpful, but again, we're really at the early days when it comes to this type of stuff. Okay. And so I was reading the list of the types of questions that some people had in terms of kind of asking, and a lot of individuals in the audience were wondering about probiotics for IBS, probiotics for IBD, and I just wanted to kind of bring you guys here just so that you can kind of look at these clinical guidelines, or you can just jot them down and then look at them at your own time. But I would really preface kind of those questions in terms of, you know, I think it's very important if one ever wants to think about taking probiotics, if you are someone with UC or CD, and discussing that with your treating specialist first, and maybe something to talk about with your treating specialist in terms of looking at this together, or things to talk about. there is research out there to say that it is helpful. Again, I'm not going to say it's helpful for everyone. And the thing is, with probiotics right now in the market, it's like a wild west. So you don't really know what you get. And a lot of the stuff that's out in the market right now has not been approved by the FDA. Or has not even been gone through clinical testing. Again, remember, there's a whole bunch of types of strains of bacteria. When they create these probiotics, they're not putting all the strains of bacteria. They're kind of picking and choosing certain types in hopes of this kind of alleviating certain symptoms. But again, everything's a little bit different. So this type of these clinical guidelines are guidelines that you can look under adult health, and you're going to be seeing that there's that they're categorized, and they kind of show you which ones actually went through clinical trials, which ones showed effectiveness rates, so to kind of help you in that decision-making process as well. Again, I'll preface it with a lot of the research that has looked at probiotics has been looking at it for IBS. Does it mean that it's not going to be helpful for IBD? No, but again, it's something that we have to kind of wait until there's more research. But again, something to talk to your treating specialist with if it's something that interests you. And a little bit about like what the gut microbe is, because I was throwing that out there. I think it's kind of important to kind of wrap our heads around it. So the gut microbe is like, there are trillions, not just millions, but trillions of bacteria that live along our GI tract, which is what we call the microbiome. And I'm not going to go through like deep dive into the science as to how this stuff works, but this is kind of a superficial overview. But all these little bacteria, they essentially produce short chain fatty acids when they're digesting fiber. There's different types of fiber. I'm not going to go in that. That's why I'm saying very surface level, but that's essentially it. And many of these short chain fatty acids are neuroactive and can influence brain processes. So an oversupply of certain harmful bacteria, pathogenic bacteria in our gut can result in inflammation, which can in turn affect our central nervous system, so our brain. And this can create mood disturbances like this heightened anxiety, disruptions, or symptoms of depression. And the effects of gut inflammation on our central nervous system might actually explain this connection between IBD flares and increased symptoms of anxiety and depression. If you remember what I was saying before, when patients are flaring, between 50 and 80% of them will be saying that, or will be reporting that they're experiencing levels of anxiety or levels of depression. And this is just one theory to kind of try to help to understand like this relationship between these two things. So before I kind of jump into, what can we do with this, I wanted to just give some takeaways, I guess you could say, in terms of like wrapping up over what we talked about today, because I think we kind of touched on quite a bit of stuff. So really, main takeaway is that the gut-brain connection plays an important role, not just in our physical health, but in our mental health as well. And this gut-brain connection is made up of many different elements. The biggies being our brain, the androgen nervous system, our vagus nerve, remember that's the telephone call, and our microbiota. And all of these things kind of influence one another, which kind of creates these effects on our gut, but also effects on our mind as well. And what we know, like I was mentioning before, that the gut-brain axis is influenced by our stress response. As a psychologist, this is the one thing that I'm most interested in. It's more of the top down, but again, there is a bottom up as well, like we were just talking about before. So knowing that there's that stress has an effect on our gut, the management of stress can not only help improve certain GI symptoms, but in improving certain GI symptoms, it might actually help to improve certain mental health outcomes as well in individuals with inflammatory bowel disease. Okay, so this is kind of the last bit of my talk. And what I wanted to do is, like I said, kind of, a takeaway in terms of like, what can we actually do with this? Like knowing that our stress response can actually play a role in terms of our GI health. You know, what can we do about this, and how can we manage our stress? And I didn't really want to spend time talking about the basic stress management skills, like, you know, go for a walk, or maybe do some yoga, or pick up mindfulness and stuff like that, because we already know it. I think I wanted to give more of a take in terms of what I see in my clinic when I'm seeing patients with inflammatory bowel disease, and kind of this is kind of the theme at which I've collected over my time working with these types of individuals. And these are themes at which I think, as a psychologist, actually increases one's kind of stress levels. And again, this is not to say that this list is not just 6 things, and these are the only 6 things, but these are the biggies that I see time and again. So the first one is that there's a tendency to people please. So what does that mean? It means that when we're a people pleaser, we tend to put the needs of others over our own needs. And doing so, we're saying, you know, yes to things that we'd rather say no to, and no to things that we'd rather maybe say yes to. And doing so, it creates a certain level of stress. And so if we're saying, you know, how do I start to manage my stress response? Well, one of the things is to start to ask yourself, like, am I a type of people pleaser? And if I am a people pleaser, how does that people pleasing actually affect my everyday life? And are there certain things that I can do in terms of kind of reducing this likelihood of me wanting to people please, knowing that it actually plays a role in not only my mental health, but it can actually play a role in my gut health as well. The next thing that I noticed, which kind of goes with the first point, is that a lot of my patients have a really hard time identifying and communicating boundaries. So what does that mean? It means, again, I have a very, very hard time saying no, even when I know that I really want to. So it could be found in many areas of our life, such as, you know, we find ourselves doing certain household tasks and we get very resentful because we're feeling that we're the only one doing these and our partner's not kind of taking on certain tasks as well. Or maybe we're someone who, you know, works really hard at work but takes on, you know, projects that aren't necessarily ours, or that friend that always drops everything for other friends. And over time, all these types of situations where we're not actually enacting our own boundaries and really making sure that we're protecting things that are good and right for us, this creates a lot of resentment. And resentment is a really problematic emotion in as much as it creates a lot of stress on our system. So in terms of kind of learning to manage our stress response, well, one thing is really learning to start to communicate boundaries. And before we can even communicate boundaries, you have to even know, like, you know, what's my boundaries, like, and what's the other person's boundaries, whether it's saying no to things, whether it's me feeling responsible for other people's emotions. All of these things are kind of opportunities to learn to create boundaries. The third thing, which I kind of talked about at the beginning of our talk, is this difficulties identifying and naming emotions. This is a huge one that I see time and again, where a lot of my patients don't have like the vocabulary to really know what's going inside of them. So they say, I'm anxious. Well, anxious is a huge umbrella term for a whole bunch of things. Or a lot of them say, I'm angry, but under that anger, there's a whole bunch of other emotions that we want to touch on, because those emotions are really there to kind of identify our needs. And if we're unable to know what those emotions are and be able to communicate those emotions, that means that we're having a whole bunch of unmet needs. And over time, unmet needs create a lot of resentment, and a lot of resentment creates a lot of stress. So again, one of the ways of reducing our stress is really learning to start to kind of look inwards, learning to kind of figure out, like, what's actually going on, what am I actually feeling, and being able to practice ways to actually communicate that. The next one is difficulties with uncertainty. So makes a lot of sense given the disease at which one finds himself with, right? Like we said, it comes with a very unpredictable and very uncertain nature. And with that, some people are able to kind of surf these waves of uncertainty, but a lot of the time, there's a high level of distress that comes with this uncertainty. So this is what we call low distress tolerance. So they have a very, very hard time managing the uncertainty that comes with their disease. And this is something that really needs to be addressed, given the kind of cyclical nature of disease and given the uncertainty that you're going to have for the rest of your life. We really want to be able to manage and relate to that uncertainty differently in a way that it doesn't stress us out. Second to last point is lots of time traveling. So people that have heard me in the clinic, I'm sure the nurses say that too. I talk about this a lot, but we have a tendency as humans, because we have a frontal cortex, it allows us to do a bunch of really amazing things. We can talk, we can think, we can imagine, but it also allows us the opportunity to time travel. What do I mean by that? It allows us the opportunity to go into the future and to go into the past. And when we go into the future and we go to the past, very rare are we thinking about good stuff. A lot of the time we're going to the future and past to think about things that we're worried are going to occur, or things that happened to us in the past that we're upset over, and we replay them in our minds over and over and over again. The problem with time traveling is that our mind, the little part in our mind that turns on, so let's say our stress response, our fight or flight mode, our amygdala, it doesn't know that you're imagining. So when we're time traveling and we're thinking about something that we're predicting is going to happen to us that's bad, that part of our brain actually thinks that thing is occurring to us in the here and now. So what does that mean? That thinks that it's a perceived threat in the here and now, and it's going to flip on our fight and flight mode, and then there's going to be all these physiological changes that happen to our body. So if we do a lot of this, where we're either catastrophizing about things in the future, catastrophizing about things in the past, that means that we're flipping on our fight or flight mode constantly, and we're dousing ourselves with a whole bunch of changes that our body is really not prepared to kind of meet and deal with. And the last thing that I'm going to kind of talk about, which I see a lot in our patient population, is feelings of shame. So again, as I was mentioning before, living with inflammatory bowel disease, it's like there's a very taboo in the sense that it's very uncommon in the Western world for us to talk about bowel movements. So even bowel movements with our intimate family members, we rarely talk about. So this idea of having this disease that affects our bowels is something that's very shameful. A lot of patients, not all patients, but a good chunk of them, in terms of they're not feeling comfortable about a big part of who they are. Because they're not comfortable with a big part of who they are, they don't talk about that part of themselves. And over time, shame grows. You can think of it like a weed. And the more that shame grows, the bigger it gets. And the more stress it creates, because it creates a certain level of threat, right? Because it's this thing that I'm so scared that if people knew, they wouldn't want to connect with me. They wouldn't think I'm worthy. They wouldn't think I'm lovable, et cetera, et cetera. So really, how do we start to reduce our levels of shame is really to do what's counterintuitive, but it's to start to talk about those certain parts of us that we feel very ashamed about. And this is one of the reasons why we started in a clinic where we started to do monthly IBD walks, where patients who are part of the clinic are able to have an opportunity to meet each other and just get to know each other, where you start to see that there's other people like you as well, and there's other part, and you as an individual is not just your disease, you're much more than your disease. And the whole purpose of it is really creating an opportunity for us to start to talk about things that we might be ashamed of, in a way that we can kind of alleviate some of that stress that comes with it. So again, these types of topics, this might not be something that you would ever be comfortable addressing by yourself. So I encourage you to, address it with like, hopefully like a therapist or, thinking about this, writing this down and talking about it with someone. But again, these are kind of biggies that I keep seeing in our population. If we're talking about how do I start to reduce my stress, knowing that reducing my stress is going to, has a potential of soothing certain GI issues or GI symptoms. These are kind of the biggies that I would say that one would want to start to look at. So that's it for now in terms of the talk. So again, I thank you all for being here and kind of listening. Here are my coordinates as well, as I was saying before. So again, if there's certain things that you're interested in, if you want to have access to certain papers, or you want to kind of get directed into a certain area that you would want to further explore, like please feel free to write to me and I'll be more than happy to kind of send you the reference list and to kind of point you in the direction of certain things that I think would be helpful for you in terms of that exploration process. So that's